Good morning. Let's begin with Module 2 of breast cancer. Today we will be talking primarily about systemic treatment. Welcome all. Along with Dr. Cynthia Villarreal, I will be coordinating this module. I am Dr. Yanin Chávarri, and we will begin with the first two presentations on the use of genomic signatures in elderly people with positive hormone receptor breast cancers. First, we will present a case by Dr. Edwin Alfonso Tejada Valerio from the National Medical Center, 20 November, from the I.S.S.T.E, and the discussion will be by Dr. Enrique Soto Perez de Celis from the National Institute of Medical Sciences and Nutrition. Come ahead, please, doctor. Thank you for this opportunity, Mexican Society of Oncology, and we're going to present this case as genomic signatures in older women with positive HR breast cancer. This is a 76-year-old woman known by us at the Medical Center, 20th November. As we can see, she has a genetic load for breast cancer, diagnosed at 50 years of age, and other history such as hypertension that is under control. Gynecological obstetrics history. She began her menses at 13 years, menopause at 49 years of age. She had 2-term pregnancies, and her last mastography was 3 years ago. Before this disease, she was reported as without this too. Their oncological history was a screening mastography supplemented with breast ultrasound with BIRADS 4C. You can see in the image a node that was reported at the time as approximately 2 centimeters. And this lesion was supplemented with ultrasound. And at the end, it was reported as a BIRADS 4C. Initially, the patient was evaluated by surgery, the evaluation of the physical exam of breasts. In the right breast, in the upper outer corner, there was a regular node, approximately 2 centimeters, a little bit less. And the exam of both axillas, including the right with no lymph node adenopathies, where ultrasound guided biopsy was done, and this is the histological report: a ductal infiltrating adenocarcinoma of a breast with an intermediate grade, with an expressive Ki-67 of 18%, and the expression of the estrogen receptor 60%, progesterone 50%, and HER2 basically negative. All the other parameters, laboratory, x-rays, and so forth, was reported as normal. This patient was subjected to a conservative surgery with a biopsy of sentinel nodes. And at the end, the histopathological report of the specimen confirms that what was previously written. The final size of the tumor is 2.1 times 2 times 1.5 and free borders, and the histological grade is reported as intermediate. And there's a sentinel node 3 positive, and at this moment, the staging of the patient, we see the staging both by the prognostic group of the OCC is 1B, considering elements such as the hormonal receptors, the histological grade. However, the clinical stage by an anatomic group, which is in practice what is most used, is a clinical stage 2B. 4 weeks post-operative, she was evaluated as a patient evaluated in the service of oncology, 76 years of age, with a diagnosis already previously mentioned with breast cancer with luminal A and a sentinel node positive, and the decision is to decide the adjuvant strategy for this patient. I don't know if the survey is active, but if we see as a question, what intervention would you propose for this patient? We see 4 options: radiotherapy with a hormone therapy, chemotherapy with a positive node with a regimen based on cyclins or not, only hormonal therapy or genomic signature. She was evaluating 21 genes and for positive nodes in this case, and the report that we have is a score of recurrence of 23, which in this case fits with an intermediate risk. And based on all of the previous description, and with this added element of the genomic signature, the proposal by medical oncology was a radiotherapy evaluation with aromatase, inhibitor of aromatase for 5 years, omit the use of adjuvant chemotherapy in this patient, and obviously surveillance of bone health. So we currently have a 76-year-old patient who has already gone through this entire process and currently is in adjuvancy with Astrosol. She received radiotherapy and she currently has a disease-free survival of 10 months. And with this clinical case, we would open it to discussion in charge of Dr. Enrique. Thank you for the opportunity. Good morning to all. I am Enrique Soto. I am an oncologist in the National Institute of Medical Sciences and Nutrition, Salvador Subirán, where we have the clinic of the elderly adult, and I'm going to talk with you about the use of genomic signatures in elderly adults with luminal breast cancer. This is my Twitter handle if you want to ask questions or make comments. So let's remember the case. It's a 76-year-old woman with a luminal A breast cancer with a positive sentinel node at grade 2. And the question is, what is the role of genomic signatures in this case or in a similar case? In this presentation, I'm going to talk about the evidence for use of genomic signatures in elderly adults, and we're going to use the definition of elderly adults of 65 years of age, although in our country by law it is 60 years, but we think rather of 65 years of age. We're going to talk about the importance of the geriatric evaluation for the decision-making and diagnosis and therapy in this context, and finally on the benefit of chemotherapy in elderly adults with the luminal A breast cancer, and finally the genetic studies are done to determine who would and who would not receive adjuvant chemotherapy. It's important to remember that breast cancer is a disease of the aged. Here is the number of cases of breast cancer worldwide diagnosed in the year 2020 and the projection for 2040 in those under 65 years of age. Approximately 1.5 million cases in 2020 and 2 million or 1.84 million in 2040. This will increase to 1,340,000 by 2040. This is impressive because elderly adults are only 10% of the world population. This means that a large population of cases of cancer are concentrated in a small part of the population. So this shows that even though in absolute number there are more cancers in young women, but actually breast cancer is a disease of the elderly, so there's a great problem. They are not included in clinical assays in general, and especially in genomic signature assays. So doesn't include 70-year-old patients, although we had 6% of elderly, and Taylor had Taylor X, so only to 75 years, but they had 4.8% of the population under study. So nearly half of the patients with cancer have this age, but they are very poorly represented in the clinical assays. So the truth is that there is very little evidence in this group of patients. And to try to resolve this problem, we recently did a systemic review of the role of genomic signatures in elderly adults. It's in the process of being published. I'm going to present some of the results. We reviewed 738 abstracts and we excluded 581. We reviewed 157 articles, and of these we excluded 152 that did not include specific information on elderly adults. So the 138 we resulted at 5 had evidence on the use of genomic signatures in elderly adult women with breast cancer, and this included a prospective assay including elderly adults for retrospective analyses. So what characteristics do these studies of elderly adults have in which the genetic signatures were used? They all had Oncotype Dx, and they used different cohort sections. Some use a section of 26, and all of them had variable definitions of what it meant to be an elderly adult, some 70, 65, or 60. And only one of the studies evaluated disease-free survival at 10 years as a primary endpoint. The others used of oncotype, what type of recurrence did the young people have compared with the elderly. And in the analyses, we know that there is disparity in the use of genomic signature in elderly adults. So in the United States, there are only 8% of the patients over 70 years of age receive a genomic test, while 18% of the ones under 70 years have this test done. So what is the recurrence score according to the chronological age? We could think that there are differences, or the truth is that in great studies, there seems to be no difference as far as the recurrence score in young people or those over 70 years of age. In the column on the left, those are over 70 years of age. And as you can see, 29% had a recurrence score of under 18, from 18 to 30, 55%, and over 30, 16%. And you see that those under 70 years of age, really the differences are very little. So we can expect to find practically the same type of genomic risk in those elderly as in young people. There seems to be no difference there. As far as the impact on recurrence and survival, the genomic tests, especially DX, do define risk groups of those over 70 years of age. So the elderly that have a score under 11 have an index of recurrence of over 3%, and this increases to 18% in recurrence scores under 25. So there is evidence that genomic tests predict the risk of recurrence in elderly adults. However, there is no evidence that doing genomic tests and guiding the treatment based on genomic tests increase the global survival of elderly adults. So why is this? Because there are other factors in addition to the type of tumor and the chronological age impact the survival of elderly adults with breast cancer. In young people, the tumor or the breast cancer normally is the major problem that patients have. Young patients will die from breast cancer, while the elderly, it's possible and sometimes more probable to die with breast cancer. And how can we distinguish which patients die with breast cancer and which ones die of breast cancer? So normally in oncology, what we present in today's case, what we evaluate is the chronological age, the type of treatment given, the organic function. We have renal function tests and liver function tests, and we stage the tumor, and we classify morbidities and distinguish the morbidities of the patient. We do an evaluation of the functional condition, which can be objective. So what is proposed today is to add to this a geriatric evaluation, do an oncogeriatric evaluation where we add criteria that we know are particularly important for the elderly in their daily life and also for the forecast of serious diseases like cancer. This includes polypharmacy, hypertension, social support, certain cultural aspects, and so forth. And very importantly, aligning all this with the patient's preferences. So what do the ESCO guides recommend? Since 2018, ESCO recommends that all those elderly that are going to begin treatment for any type of cancer receive a geriatric evaluation that should increase at least an evaluation of functionality, comorbidities, depression, cognition, an evaluation of falls, and the nutritional condition. In Mexico, for a couple editions, the Colima consensus also recommends that all the elderly women over 65 years of age with breast cancer have a geriatric evaluation before planning treatment. And how can the geriatric evaluation help us to determine the value of the genomic tests or the adjuvant treatment? It helps us to calculate the life expectancy of the patient. So there are several methods to calculate life expectancy. In many cases, what is most used are actuary tables, which are used for non-specific conditions, but these have many limitations because they are not personalized. And there are calculators based on geriatric evaluation that include geriatric elements to predict survival of patients. And these calculators are on this page that's called ePrognosis. ePrognosis, recommend you use it. It includes calculators for several different horizons of time. And in this revision by Dr. Verduzco, you can read how to use these calculators in the daily practice. There are two calculators that I think can be used in this context: the index of Lee-Schomburg, which was recommended by ASMO. This predicts mortality to 4, 5, 10, and 14 years, mortality from all causes. And the problem of it is it's developed in U.S. population, and the index of II-SMEO2021, which was developed in Brazil, predicts mortality in 10 years and includes European, Brazilian, and Mexican population, and then a survey of aging. It has a discrimination of 76% to predict the life expectancy in 10 years. How does this index used? I'm going to show it here. We're going to add some things of the patient and create two figurative patients. Let's imagine that this is our patient, and we are going to split her in two, make a twin. So these two 76-year-old women and both have breast cancer. So patient one, maybe 76 years with breast cancer, has cardiovascular disease, no pulmonary disease. According to the recommendations of ASCO, when we do these calculators, we should imagine that the patient doesn't have cancer because we want to see what would be the life expectancy of the patient without cancer. And the patient one never smoked, doesn't drink. The body mass index is 26. She does physical activity. She can bathe alone. She walks blocks without help. When she asks the date, she remembers, and her general health is good. These 5 variables are things that are normally asked in the geriatric survey. Patient 2, on the other hand, smoked, doesn't have periodic physical activity. She can bathe, but she can't walk several blocks without assistance, has difficulty remembering today's date, and her general health is poor. So they're the same chronological age with the same oncological disease, but if we predict her life expectancy, patient number 1 has 72% of probability of living in 10 years, and patient 2 has only 35% of probability of living in 10 years. So this is very important when we are going to give treatments that offer additional gains, in some cases small, for survival, such as what we achieve with adjuvant chemotherapy in the case of positive hormone receptor cancers. Same tumor, same chronological age, different outcomes. So how can we use this in a clinic? Probably many of you have used the PREDICT tool, which is a tool developed in the UK and a general population that has breast cancer, and that attempts to establish the advantage of survival to 5 or 10 years with the adjuvant treatments. And here I mentioned the data of our present and PREDICT with positive hormone receptors, 76 years. And what it predicts, what PREDICT predicts is that the life expectancy would be between 40 and 60% at 10 years, which is similar to the healthy patient on the previous table, and the benefit of adjuvant is 4% with hormonal treatment and 3% with cytotoxic chemotherapy. So a patient that's going to live or has a probability of living in 10 years of 70%, maybe this 3% she'll live those, but the patient that has a life expectancy of 35% in 10 years, the benefit of that 3%, of the meeting of 3%, is uncertain at the best. And not only that, but we should also contrast that benefit of survival with the risks of the treatment. Because why are they particularly important, the risks of treatment in elderly adults? Because it is well known that elderly adults have a greater risk of toxicity when we give cytotoxic chemotherapy. And randomized clinical tests, when they're highly selected, about 50% of the elderly adults present some toxicity grade 3 to 5, which are the toxicities that limit self-care, they're hospitalized, or they kill you. So this is certainly something to take into consideration when we give chemotherapy in elderly adults, not only toxicity, but also long-term effects. In this paper, which was published a couple of years ago in the Journal of the American Geriatric Society, we studied the functional outcomes of patients with breast cancer that received adjuvant chemotherapy. And what we saw that was about half of the patients had a decrease in their functionality by the end of the chemotherapy. So they had lost the capacity for doing at least some activity in their daily life. And of these patients that lost that functionality, only half recovered it after a year. What does that mean? That a percentage that is considerable of the patients after giving chemotherapy, we are causing them to lose the capacity for doing things that they could do before. That damages their independence, their functional role in the society. Why is this important? It seems obvious, but when we ask patients, elderly adults, what they prefer, not necessarily do they prefer to live as long as possible. We did this study that we presented a couple of years ago in ASCO, and where we asked the 241 elderly adults with cancer, 25% of them had localized tumors before beginning treatment, to prioritize different results or outcomes using validated tools in the US. And although about 58% of the patients selected living as long as possible as the most important factor, practically half of the elderly adults preferred other outcomes over survival, such as conserving their independence and avoiding symptoms. And 80% of the patients said they preferred to die rather than lose their cognitive capacity. And we know that's another potential outcome of adjuvant chemotherapy. So certainly we have to take into consideration the preferences of the patients and outcomes from the moment that we request a genomic test, because when we have the results, we need to act consequently. So should we use genomic signatures in elderly adults? We don't know for sure. Perhaps one of the best studies that show what would be the potential benefit of the study by Dr. Mendez, published last year in the GenCI, where they did a stochastic simulation with a horizon of 25 years, taking into account age and comorbidities, and they tried to simulate the qualities, which are age-adjusted lives that could potentially be gained by giving adjuvant chemotherapy to an elderly adult. The blue curve are patients without comorbidities, patients in excellent health, like our patient of column 1. And as you can see, between 65 and 69 years of age, there seems to be a benefit in qualities of giving adjuvant chemotherapy. But by 75, it seems that there's damage in qualities. This is due to toxicity. If we look at the group with comorbidities, in no age group after 65 years of age is there any benefit. And for persons with comorbidities, such as the ones that we mentioned, only between 65 and 69 could there be a benefit. After 70 years, this benefit is lost. And this is due to the fact that the patients have other things and other competitive risks that are more dangerous than cancer. And here I'm showing the calculation of the benefit of survival with adjuvant chemotherapy in 65 to 69 without comorbidities is 5.1%, and all the rest have very little or no benefit. The meta-analysis of the EBCTCG is another evaluation of this aspect. 1,000 patients, only 552 were over 60 years of age, and only 52 were over 70 years of age. There seems to be no benefit of chemotherapy in this subgroup, patients with positive hormone receptors. This year, we published the recommendations of the International Society of Geriatric Oncology and EUSOMA, where we did some recommendations for treatment of adjuvant therapy with these patients. And our recommendation, the specific recommendation in the context of positive hormone receptors, is that there's no evidence for use of genomic signature in elderly adults in the same way as in young patients. When we take this into consideration, it's important to include the geriatric evaluation of life expectancy, and we only need to consider this when we predict a significant benefit of chemotherapy. In the Oxford group, they consider that a significant benefit in the context of adjuvancy with chemotherapy makes sense in an elderly person is when the benefit is over 5%. Between 3 and 5%, the benefit is doubtful and should be evaluated. And when we predict that the benefit is less than 3%, it's better not to use it. One of the studies that is currently ongoing and will give an answer to this is the ASTER-70 study. by Dr. Brain in France. And what they are doing is including patients with breast cancer localized of 70 years of age or more after surgery that are hormone receptor positive, where they are calculating life expectancy with the lean index. All the patients are doing a geriatric evaluation briefly with the G8 tool, and the patients that have high genomic risk, which are the ones that are in group 1 of the blue square, those are randomized to mono with hormone or chemo. And the idea is to see if in these elderly patients, but with a life expectancy that's predicted for 10 years at least, the benefit of chemotherapy looks the same as in young people. So we select them based on the life expectancy. It's individualized in geriatric evaluation. This study has already concluded recruiting, and we expect in ASCO 2022 we have some results. So going back to the case, this is a 76-year-old woman with a breast cancer, which is hormone receptor positive. Her prognosis depends on survival, not cancer specific. There is little or nil evidence of benefit of adjuvancy with chemotherapy in these patients of over 75. This patient does not require genomic signature, and this is something that I would give aromatase inhibitor for 5 years. The only context would be a patient that is completely fit with no geriatric problem. And even so, in those patients, it seems there's no benefit of adjuvancy. So there's little evidence for using genomic signatures. However, and we must take this with a grain of salt, because according to as the life expectancy changes and the health of the population changes, it's possibly that this recommendation will change as well, as say with the screening age that goes up and up and up in the developed world, because people live longer and longer and more healthy. So in summary, what do we need to do in these contexts? Evaluate the clinical risk, define the treatment objectives and the preferences of the patient, calculate the life expectancy in a specific cancer, and evaluate the risks and benefits of treatment. And finally, with all this information, make a therapeutic decision and a diagnostic and therapeutic decision. This is the ideal context to mix the disciplines of geriatrics and oncology. All the oncologists that I heard this an opportunity to include geriatrists and their team, and that is what we seek in geriatric oncology. Thank you very much for your attention, and I'll wait for your questions. Thank you very much, Dr. Soto, for an excellent discussion of this clinical case. Are there any people, is there anyone in the audience that has a question? If not, I would ask, so in elderly women over 70 years of age, say the rule would be not to use a genomic signature unless the geriatric evaluation and the life expectancy is excellent. Yes, I agree. At the end of the day, what we need to consider before requesting the genomic signature, would I give her adjuvant chemotherapy? If the answer is no, she won't benefit with adjuvant chemotherapy or has competitive risks that eliminates the benefit of adjuvant chemotherapy, then the genomic signature makes no sense. So we need to think one step ahead in that regard, and only request it in patients where it would be high risk, we would give chemotherapy. So the way to determine that is going beyond the tumor, including these other variables of life expectancy, risk of toxicity, and so forth. We have a question regarding the clinical case. It's regarding whether they completed the axillary dissection. Dr. Tania Alvarez from the Naval Medical Center. Was it macrometastases or by sentinel node? I don't know, for example, if this would change the decision regarding doing or not doing genomic signature. Well, Dr. Tejada answers actually in a 76-year-old patient, even doing a sentinel node, and that could be another presentation regarding whether or not it is wise to do sentinel node in people over 70 years with early hormone-sensitive tumors. Actually, the surgical oncology group recommends not doing sentinel node in these patients. So there's doubts in this regard. In this patient, I don't know what you did. So if there are 3 nodes, it wasn't behavior that was performed. It's an elderly patient. We need to take into consideration the comorbidities that could be added, as the doctor mentioned, but only 1 sentinel lymph node, and it was macrometastases. So if it were micrometastases, it changes according to the clinical risk to order genomic signature, but if you don't complete the axillary dissection, that wouldn't help in this case. I will applaud.
Thank you. Thank you so much, Enrique, on the presentation. And how nice how this was all related to the context of the clinical patient. Let's move on to the second block. And continuing with the same topic, now we will talk on the use of genomic signatures, but on the other spectrum of life. This is young women with hormone sensitive cancers. And for this, Dr. Angel Lara Carvarin will present a case to us. He's a resident of the National Institute of Medical Sciences, as well as nutrition. Then Dr. Hatem Asim, he's a resident there, an honorary professor of the Technological Institute of Monterrey, will proceed discussing the case. So, Dr. Lara, you have the floor, please.
Hola, muy buenos días a todos.
Good morning, everyone. Let's move on with the next part of the session. This is a clinical case as well.
Puedan dar la siguiente.
Can we please put up the next slide for me?
Entonces, esta es una mujer de 46
So this is a 46 female premenopausal patient. She was previously healthy, no family history of cancer.
Ella inició su sintomatología
She
en
began
agosto
with her
2020,
symptomatology in August 2020 with a non-specific pain of the left breast.
Entonces, se realizó un
And
estudio
because of
de
this,
imagen, una mastografía,
she got an ultrasound, a mammogram, and an ultrasound, and a study was reported of 2.9 centimeters. It was a speculated mass, and it was a BI-RADS 2.5. So a biopsy was performed, and the pathology report was that it was an infiltrating ductal carcinoma, grade 2, with estrogen receptors 80%, progesterone receptors 80%, HER2 negative, and a Ki-67 of 20% as well. No evidence of axillary disease on her previous imaging. So because of the tumor location and because of the size of the patient's breast, the decision was made to mastectomize her with sentinel node. And the report is that it was grade 2 invasive carcinoma. 2 nodes were obtained and they were all negative. So with this information, the first question that I would like to address is, what is the best management for this patient, considering that she's a T2N0, an anatomical phase 2A and a prognostic 1B phase with positive hormone receptors, Ki-67 of 20%. So I was told that there is no option for an online survey, but maybe the audience here would like to raise their hands, answering to us who would vote for an Oncotype Dx to guide the therapy for this patient. Who would agree with this? Please raise your hands if you're so kind in order to vote. If you believe this is the best option. Okay, now this is a high clinical patient, high clinical risk patient, according to the MIND Act. Okay, we see some hands raised for a mama print. Now, this is considering that we have abundant resources, but would anybody, despite the abundance of resources, would prefer no platform and just provide adjuvant chemotherapy plus endocrine therapy to this patient? Okay, nobody. And the last one, not to request any platform and simply provide endocrine therapy. Okay, so most would use any of the two platforms with slight predominance of Oncotype. Now, in this case, this was exactly what was done, an Oncotype, and there was a recurrence score of 25 points, which is still intermediate risk in the limit between 25 and 26. So with this information, with a recurrence score of 25, premenopausal 46-year-old female patient, what would be your management and your recommendation for her? I'll give you just a couple of minutes for you to read the options. And please, in the audience, answer who would provide adjuvant chemotherapy plus endocrine therapy, which would be an IA plus or an aromatase inhibitor plus ovarian suppression. Second option, adjuvant chemotherapy and endocrine therapy, tamoxifen plus ovarian suppression. Well, I see also some hands raised. Endocrine therapy, AIs, no adjuvant chemotherapy, just ovarian suppression with double the blockade. We see some hands, and endocrine therapy alone with tamoxifen. I see a hand in the back. Also, this patient was explained the options and the risks that we know based on the trials that we have, and the decision was made to give her adjuvant therapy, TC for four cycles, and after that, endocrine therapy was begun. At this point, although the patient has undergone chemotherapy, and now we will move on to the endocrine therapy, in your opinion, what would be the best choice after having undergone chemotherapy? An AI plus ovarian suppression, several hands, tamoxifen plus ovarian suppression, and tamoxifen alone, or endocrine therapy plus abemaciclib, that is any endocrine therapy but adding the cyclin inhibitor. So most of you say that an AI plus ovarian suppression. Okay, so this is the last slide. In the case of this patient, we decided on a double blockade with an AI plus ovarian suppression. She is with disease-free survival from the moment of her surgery. This is about 6 years ago. So let's move on with Dr. Hasim's lecture.
Good morning, everyone, and
Buenos días.
To thank the organizers for the invitation, and it's a real pleasure to be here today for the second time. So today I'm going to discuss with you the use of genomic signatures in breast cancer, particularly with a focus on young women, whether it's really different, our appreciation of the use of genomic signatures in young patients. So these are the points that I'm going to discuss with you today. So just a few slides first on genomic signatures just to make sure that we are all on the same page. And then I think before going into the data, discussing the role of genomic signatures in young breast cancer patients, I think it's relevant to highlight first what's unique about breast cancer in young women and why the question of using genomic signatures in young women could be particularly special. And then we'll go on through the data of the use of genomic signatures to optimize the choice of adjuvant therapy and whether this differs when it comes to a young patient. So as you all know, currently we do have different genomic signatures that are being used in clinical practice, Oncotype Dx being the most studied, possibly the most widely used, but there are others already that are available, as you could see here on the slide, the MAMA print, the ProSigna, and so on. And irrespective the signature we're talking about, these signatures are only informative in patients with ER-positive disease. So you could see here on the slide, for example, you have 3 different signatures as highlighted here in blue, and then you have 3 subtypes: ER-negative, HER2-negative, HER2-positive, and ER-positive, HER2-negative. And as you could see, for example, if we take the first panel, which is the Oncotype Dx, we could see that patients with ER-negative, HER2-negative, or HER2-positive, they are all classified as high in red. However, in the ER-positive, HER2-negative, you have 2 groups, high and low, which correspond to high risk or low risk, or high proliferation and low proliferation. This is what we call as well luminal A and luminal B. And that's why these signatures are not at all informative when it comes to a patient with triple-negative disease or HER2-positive disease, but they are only informative to have 2 distinct groups according to risk only in ER-positive, HER2-negative disease. So several studies have been shown, and this is just to remind you that, for example, this is the data with Oncotype Dx, and you could see on the x-axis, this is the recurrence score, the Oncotype score, and the y-axis, this is the risk of recurrence. And for example, here you see study in node-positive and study on node-negative disease, and the higher the recurrence score on the x-axis, you have a higher risk of distant recurrence. This is also observed with the other signatures. This is, for example, the data with MammaPrint, showing that even in patients classified using a clinical classifier, in this case, Adjuvant Online, so among patients with high clinical risk, on applying the signature, you could still see that this signature could differentiate 2 groups of patients according to their MammaPrint score, a high risk and low risk with distinct outcome, despite all being classified as high risk by a clinical classifier. The same applies as well with another signature like the EndoPredict, in which you could see as well, if you use a clinical classifier, in this case, for example, the St. Gallen criteria, you could still have 2 distinct groups, high and low, with distinct outcome according to the genomic test. I think the main message of this slide is to see that the genomic tests appear to add improved prognostication beyond the classical clinical classifiers that we use in clinical practice. So what is unique about breast cancer in young women, and why really the question of the use of genomic signatures in young women could be rather different? So first of all, data for several decades now have shown that younger patients are more likely diagnosed with a higher stage tumor, node-positive tumor, and less ER-positive tumors compared to their older counterparts. Furthermore, it appears that within the ER-positive population, you do have a lower chance of having a luminal A disease, which is the slowly proliferative ER-positive tumor. And this is a study showing, you could see the different age groups, and in blue, this is the luminal A, the slowly proliferative ER-positive tumor, and you could see that's only 17% in younger patients compared to around 30 to 35% in older patients, which also highlights that the ER-positive disease in younger patients is rather different in terms of distribution between luminal A and luminal B. Importantly, that younger patients have been shown to have poorer prognosis, but this poor prognosis is mostly restricted in patients with ER-positive disease as well. So you have luminal A and luminal B in the upper panels, and you could see in red the patients less than 40 having an inferior disease-free survival. However, in patients with HER2-positive disease or triple-negative disease, the outcome is rather comparable. So in younger patients, they have poor prognosis, and this poor prognosis is mostly in ER-positive disease. And as we discussed earlier, the ER-positive disease is the subtype in which the genomic tests are more informative. So when we dig deeper in the biology of breast cancer in young women, we'll find that they have also different pattern of somatic mutations. And here in less than 45 patients, you could see that we have PIK3CA mutations, which is in around 27% of patients. However, the percentage is much higher in older age groups. PIK3CA mutation is a mutation that is predominantly present in ER-positive disease and has been shown also to be associated with better prognosis in breast cancer. So younger patients have lower prevalence of a PIK3CA mutation, which is only present in ER-positive or predominantly present in ER-positive disease, and associated with good prognosis. So having said that, it appears that the breast cancer in young women is relatively unique from a biological standpoint, but it's mostly in patients with the ER-positive subtype that their outcome is different, and the genomic profile or their molecular profile is rather different. And that's why the question on the use of genomic signatures in young patients could perhaps have a different interpretation than older patients. So we have done an interesting work by the group here in Monterrey led by Villarreal Garza and her colleagues, showing clearly that in younger patients, it appears that they are more likely diagnosed with a high genomic risk tumors. And you could see here, this analysis, you have EndoPredict, MammaPrint, and Oncotype, and you could see that in low genomic risk, you always have a lower proportion of younger patients diagnosed with low genomic risk tumors, irrespective the genomic test you test, which could make sense because, as we discussed earlier, ER-positive tumors diagnosed in younger patients are less likely to be luminal A rather than luminal B, so they have more highly proliferative ER-positive tumors, and that's why this could potentially explain why we're seeing a lower proportion of patients with a low genomic risk in younger patients. This does not mean that they all classified as high risk. Certainly, there are still low-risk patients diagnosed at a younger age, however, at a relatively lower prevalence compared to older counterparts. Importantly, in recent years, we now have data showing that in younger patients, there are more than one effective treatment option in terms of adjuvant endocrine therapy. So we have, as we discussed in the case, we have tamoxifen, we have ovarian function suppression plus tamoxifen, and we have ovarian function suppression plus exemestane. So are these three options equivalent? The answer is no. In very low-risk patients, as you could see here, with low Ki67, high ER/PR status, and node-negative disease, they are almost identical. As you could see here, outcome is around 98% for all of them. However, when you start to have higher stage tumors and higher Ki67, for example, you start to see the difference between them. You have here a difference ranging somewhere between 5 and 10% in absolute difference between tamoxifen and ovarian function suppression plus exemestane. So this is very important as well because this data has been generated relatively recently, and we will discuss it later in our interpretation of the genomic signature data in young breast cancer patients. But it's important to keep this in mind, that this data currently is being incorporated in clinical practice because of the difference of the improvements of ovarian function suppression plus exemestane over tamoxifen, mostly in relatively high-risk patients classified by high proliferative index or node-positive disease. So what about the role of genomic signatures in informing on the adjuvant therapy or the choice of adjuvant therapy, and whether this differs from young patients to their older counterparts? So starting first with this study that I'm pretty sure that you are well aware of. This is the TAILOR-X study evaluating the role of Oncotype Dx on informing on the need of chemotherapy, particularly in the intermediate group, which is a score between 11 and 25. These patients were randomized to either hormonal therapy alone or chemotherapy followed by hormonal therapy in all patients irrespective of their menopausal status. So when we look into patients with low genomic risk by Oncotype, treated only with endocrine therapy, the outcome was excellent, with around 9-year disease-free survival around 97%, proving that if you have a patient, irrespective of age, if you have a patient with a low Oncotype score, less than 11, endocrine therapy is very effective, and there is arguably no benefit at all of a potential benefit of chemotherapy in this setting. However, in the intermediate risk, I think the question was there. So these are patients having a score between 11 and 25. And you could see here, this is all patient combined, irrespective of menopausal status. You see here that the outcome was identical at 9 years between both groups, with around disease-free survival in the 95% range. Another study, but this time in node positive, which is responder, looking into patients for 1 to 3 positive nodes, focusing on patients only with low and intermediate risk, both. So a score up to 25, randomizing patients to chemotherapy followed by endocrine therapy compared to endocrine therapy alone. And again, the outcome in the whole overall population, irrespective of menopausal status, was identical almost between both arms, arguing that even if you have a patient with a node-positive disease, particularly node 1 to 3 positive nodes, chemotherapy does not add benefit over endocrine therapy in this patient population. However, I mean, when we look into in premenopausal patients, we would see that there is a tendency of different interpretation of genomic tests between premenopausal and postmenopausal to inform on the need of chemotherapy. What do I mean? That, for example, in this analysis, this is using Oncotype Dx, you could see that patients with a low risk, less than 11, there was a higher proportion of patients, young patients, less than 40, offered chemotherapy compared to their older counterparts. The same applies for intermediate risk and high risk, which means that there is a tendency within the oncology community among medical oncologists to treat young patients differently when it comes to the interpretation of genomic tests, offering on average more chemotherapy to patients despite being classified as low risk and intermediate risk. So why is that? So let's look deeper into the data of TAILORx and Responder regarding the analysis in younger patients. So this is the data in TAILORx. So I remind you, TAILORx is a study focused on node-negative patients. So this is the data I presented to you earlier in all patients. You could see the absolute risk at 9 years or disease-free survival at 9 years in less than 11 in the intermediate group and the high-risk group with chemotherapy. This is the data in less than 50 years. So this was almost 30% of the population. So I'm showing you now the data in the less than 11, an outcome which is identical to the general population. And the outcome in the more than 26, chemotherapy followed by endocrine therapy, again, an outcome which is rather identical as well. So the first message here, that there's absolutely no argument that if you have a patient with a low-risk Oncotype Dx, to offer her chemotherapy, because the outcome is exactly identical. However, the argument or the debate in this study was pretty much in the intermediate risk group. So I'm breaking it down now to intermediate risk group from 11 to 25 to 3 groups. And you could see, for example, in the group between 11 and 15, and here we're talking about young patients, there was a tendency that the outcome with chemotherapy was a little bit better. As you could see here, an absolute difference of around 3%. When we look into 15 to 20 or 21 to 26, you will see that the delta between both arms was relatively more important, somewhere between 5 to 8%. However, it is important to mention that in this study, only 15% of young patients were treated with adjuvant ovarian function suppression. As we mentioned earlier, the introduction of ovarian function suppression over tamoxifen, and in addition to tamoxifen or exemestane, added an absolute benefit somewhere in the range of 5 to 10%. In this study, most of these patients, premenopausal patients, 85% were treated with tamoxifen alone when randomized between hormonal therapy and chemotherapy. What about Responder? This is the data in postmenopausal and premenopausal. So on the left panel, you could see postmenopausal, the outcome was rather identical between chemotherapy or hormonal therapy. However, in premenopausal patients, there was an absolute difference of around 5% in favor of chemotherapy, with a positive interaction, which indicates that this subgroup analysis indicates that there was a significant difference in favor of chemotherapy compared to endocrine therapy in premenopausal patients. However, again, in this study, only 15% of patients were treated with ovarian function suppression. So in the premenopausal patients here, 85% of them were offered only tamoxifen versus chemotherapy followed by tamoxifen. I think it's very relevant to take this into account when we interpret the results of these studies. And the debate was pretty much whether there is a real benefit of chemotherapy in the intermediate risk group in young patients. And here the benefit that we have seen in the studies in somewhere in the range of 5 to 7% with chemo. However, I would like to remind you, of course, it's difficult to compare studies, to compare results across studies. However, the benefit of ovarian function suppression currently It's relatively uncontested, particularly in high-risk patients who have a relatively high proliferative disease, high Ki67, and arguably patients in the intermediate risk group have a proliferation index that could be relatively higher compared to patients with the low-risk group, the low-risk Oncotype Dx. That's why I think it's very important to take this into account when we think of offering more chemotherapy to young breast cancer patients in the low and then particularly in the intermediate risk group. So another question regarding the adjuvant therapy, could gene signatures inform on the role of extended adjuvant endocrine therapy? So I just would like to remind you two facts. First, that now we do have evidence for several studies showing that extended endocrine therapy with up to 10 years could be beneficial in patients. We know that it's not necessarily needed in all patients, but we know that on average it adds a benefit in terms of disease-free survival compared to 5 years of tamoxifen or 5 years of endocrine therapy. Importantly, it is important also to take into account that these patients, even if you have a patient with a T1 disease, which is the left panel, and T1N0, free of recurrence at 5 years, her risk of recurrence at 20 years is almost 13%. So even if you have a very small disease, these patients have a residual risk of recurrence and the long term, hence the need or hence the argument of extended endocrine therapy beyond 5 years. In recent years, there have been several genomic tests trying to investigate whether they could predict accurately the risk of long-term recurrence. This is data with one of these genomic tests, which is the Prosigna, the PAM50. You could see that the x-axis here starts at 5 years. So all these patients were treated only with endocrine therapy for 5 years. They were free of recurrence at 5 years, and they will followed up to 15 years. And here we did the test to classify the patients into 3 groups. And you could see that these patients who were classified as low genomic risk had a risk of recurrence at 15, from year 5 to year 15 of less than 3%. Arguably saying that possibly these patients would benefit of any further therapy. However, maybe the therapy would be mostly beneficial in the patients in red who were free at recurrence of 5 years, but have a risk of recurrence up to almost 20% at year 15. So this hypothesis was recently challenged in one of the studies, which is the ATOM trial. The ATOM trial have offered 10 years of tamoxifen versus 5 years of tamoxifen. So in this analysis, they took only patients with node-positive disease, because arguably these are the patients with a higher risk of developing late events or events in general. These patients, around 600 patients, were all free of relapse at 5 years post-tamoxifen. And they looked whether a genomic classifier could tell us whether it could identify patients that would benefit the most of extended endocrine therapy up to 10 years. And in this study, you could see this is on average the risk of recurrence in all population. And you could see that this risk of recurrence in the low risk group, absolutely patients who were classified as breast cancer index low, had absolutely no risk, had no risk of recurrence at 10 years. However, all the events or most of the events were pretty much in patients classified as breast cancer index high, which argue that a genomic classifier could potentially help in identifying those patients who could benefit the most of extending the endocrine therapy beyond 5 years. So I will end with this slide. So this is an algorithm that we proposed at ASCO a few years ago in order how to integrate genomic testing in deciding for adjuvant endocrine therapy or adjuvant therapy in general in patients with ER-positive disease. So this is regarding the choice of chemotherapy. And in younger patients, patients with a luminal B profile, high risk by Oncotype Dx or other classifiers, but I think the data out there are strongest for Oncotype Dx for this. These patients are the optimal candidates for chemotherapy. However, if you have a patient with a luminal A-like profile and low risk by Oncotype Dx, these patients would forego chemotherapy. The same applies as well for the role in extended endocrine therapy beyond 5 years. These patients with a high clinical risk, but also there could be a potential use here of genomic testing. In my view, there are a lot of data coming out again to confirm what I've just shown you with breast cancer index in ATOM. Other studies are being generated now, or other results are being generated now in other studies to confirm the role of genomic tests
No,
in this
aquí a
setting,
través
but
de
I
la
think this is
pantalla de
something
Zoom.
that we could
Vale.
look forward
Le va a
to
llegar
more
un
data
aviso
in
en
the
su
coming,
pantalla, por favor de aceptar, y ahí le
months
doy
and
el
years.
resto de las
Thank you very much for your
instrucciones.
attention.
I'm going to say the questions in English because you don't have the translator. So there are two questions from the audience. The first one is, so you're presented the data and responder for the node-positive patients, and we should not do these tests for node-positive patients if they're young or premenopausal, right? What about another signatures, MammaPrint, EndoPredict, or would we have any choice?
Well, honestly, my message, my interpretation of the responder, that I would do it in node positive patients. I would do it in patients from 1 to 3 positive nodes, even if they are young. But my position that I would just treat them with adequate endocrine therapy, and adequate endocrine therapy in these patients is not tamoxifen alone, as was done in this study. Of course, when the study was initiated, we didn't have this data, so it's not a critique for the study, but this is the data we had at the time, that we were not certain that we need ovarian function suppression for these patients to improve outcome. This study has been generated after the study has been almost completing, and that's why it was not applied. I do not make a major distinction when it comes to nodal status, when it comes to the use of genomic testing. Of course, the data we have currently is for node negative and 1 to 3 positive nodes. So I could take that, but arguably if you have a patient with 10 positive nodes, the question is, when you give chemotherapy to these patients still has a residual risk of almost 50% to recur anyways, even if you give chemotherapy. The question is whether if you treat them if you have a low risk patients among these patients, whether you give endocrine therapy alone, whether this 50% would be 30%, and I don't think so, but we don't have the data, of course. But I have no problem using Oncotype Dx in patients, premenopausal patients, with 1 to 3 positive nodes. If they are low or intermediate risk, in this case, I would give them ovarian function suppression, possibly with an AI, as an option. Of course, if some of us are more comfortable giving them chemotherapy, I could understand that. But personally, I do not think if there is a difference between both, it would be really marginal.
And would you use or have the option to use the other signatures, genomic signatures?
Well, of course, we are always more comfortable using the signature with the most robust or the most solid data. And the most solid data today is for Oncotype Dx. And I doubt that a lot of other signatures would be doing prospective studies to generate data in this form. I do not think, but nevertheless, so this is the data. If you ask me about whether I think there's a major difference between the different signatures when it comes to, for example, the use of adjuvant chemotherapy, I don't think so. For example, if you don't have access to Oncotype Dx, but you have access for example, EndoPredict or MammaPrint or Prosigna, these are very, in my view, very good signatures too. The data out there regarding their analytical validity and clinical validity is established. They might not have been tested in the same setting of Oncotype Dx for sure, but I think they could provide you with pretty much comparable information to help you in the decision-making process. Another point I would like to add, that I do not base my decisions whether to give or not to give chemotherapy only based on the genomic test. So the genomic test certainly is an added factor compared to the other parameters that you need to integrate. So it's not also an isolation, but I think the other signatures would provide you with comparable information to what the Oncotype could provide you to help you make the right decision or the optimal decision for your patient.
The second and last question for Dr. Lara's case. So she was a young woman. She was about 46, as far as I remember. She had a T2N0 or hormone receptor positive, HER2 negative disease, and she had an oncotype of 25. So we would choose to do chemo. Would that guide you on what or which regimen of chemo would you choose for her, either TC or would you go for the whole ACT treatment?
Well, of course, the thing is with these scores, that 25 is pretty much, so if she was 26, which is the first score in the high risk, would we have treated her in a different way? And of course, it's intriguing because what's the difference between 25 and 26? I mean, in reality, even if we have this dichotomy between intermediate and low risk. So I can understand pretty well. And this is pretty much the situation that you need to engage the patient in the discussion and to understand her position as well when it comes to her appreciation of benefit and appreciation of risk and what's really her look into that. I wouldn't make a major distinction between a score of 25 or 26, although this is classified as intermediate risk and this is classified as a high risk. I think both decisions are valid. To offer chemotherapy followed by endocrine therapy, I could understand that. I would be comfortable as well in offering optimal endocrine therapy alone as well. She is a node-negative disease. Her absolute risk of recurrence over her lifetime is small, okay? Because she has relatively a small disease and a node-negative disease. So I would be also comfortable offering her ovarian function suppression and AI. The other question is, when you use chemotherapy, and it's always the debate, when you use the chemotherapy, shall you use really the full spectrum or and I don't think we do have, we don't have evidence on that for sure. I think in this patient, because again, her absolute risk of recurrence is not high, I don't think there would be a major difference in terms of absolute benefit from offering an ACT versus TC. We never compare them together. But in node-negative disease, these patients at 10 years, this patient, if we forget for a while her oncotype score, this patient at 10 years with tamoxifen alone has a disease-free survival of around 87%, So we adding ovarian function suppression and if even a little bit of chemotherapy. So I think we should be fine. I don't think there will be an absolute benefit from offering more aggressive chemotherapy, although I would acknowledge this is certainly not a wrong decision, but I don't think there will be a major benefit here. And here it comes the position of the patient. So if you have a patient that is very conscious about every 1% benefit that she could achieve and she's okay taking some toxicity even if with marginal benefit, here you go for the full spectrum and you give her the maximum therapy you could give. You give an ACT and then the best adjuvant endocrine therapy. But if you have another patient that is very concerned about the toxicity associated with chemotherapy, in this case, you could address the situation in a different way. And I would argue that the benefit of chemotherapy in this case wouldn't be huge. If any, it would be really down to 2% range or something like that, which is, for some patient could be relevant. And maybe here you could discuss it with her, especially if she's young. But I would say that this argument is not necessarily focused on being 46. I think it applies even if she was 56 or, yeah.
Thank you,
Thank you
very
very much.
much. Gracias, Dr. Lara, por el.
Thank you, Dr. Lara, for the case. And let's continue with the forum. The next block will be a debate, a downscaling treatment of 1C and HER2 positive breast cancer. The presentation of the clinical case will be by Dr. Daniela Vázquez Juárez from Zambrano Hellion Hospital of the Monterrey Tech. And subsequently, in favor, we will hear from Dr. Sara Horvitz from UCLA, John's Cancer Center in the United States, and against Dr. Sandra Franco from the County Clinic of Bogota, Colombia. Thank you. Go ahead, doctor.
Buenos días.
Good morning.
Buenos días, vamos a continuar con la
Morning.
presentación.
Let's continue with the presentation of the clinical case.
Se trata de una mujer
It's a postmenopausal woman of 57 years of age, Mexican, non-smoker, married, 6 children. The last menses was at 53 years of age. She denies oncological family history of importance, and as medical history, she has a diagnosis of dyslipidemia since 53 years of age with dietary control and no other medical, surgical, or gynecological history. The current disease began in January of this year. There was a mammography and a screening ultrasonogram, which was rated as BI-RAD 5, with 2 lumps in the left breast of 10 millimeters and another 13 millimeters in the major diameter, large diameter. In January of 21, it was supplemented with magnetic resonance, practically the same results. She was subjected to a biopsy of the left breast, which reported infiltrating ductal carcinoma and negative for hormone receptors and positive for HER2, with a KI of 65-20%. So with these findings, we established the diagnosis of a left breast cancer, stage 1A, with a T1CNO-MO, HER2 positive. She was clinically asymptomatic with an excellent functional study, an ECOG of 0. Laboratory tests, routine tests were done, and they were all within normal parameters. And to the HER2, thinking of the anti-HER treatment she would receive, we did an electrocardiogram with a result of ventricular ejection of 67%. For the audience, what would be the sequence of treatment that you would recommend in this case? And as option A, surgery initially, followed by adjuvancy with chemotherapy and trastuzumab. B, neoadjuvancy with chemotherapy and anti-HER therapy, followed by surgery and subsequently adjuvant trastuzumab. Neoadjuvancy with chemotherapy plus anti-HER treatment, surgery, and then adjuvancy according to the pathological response, TDM1 or on trastuzumab, and the option of adjuvancy only with anti-HER2 without chemotherapy, followed by surgery, and then adjuvancy anti-HER plus or without chemotherapy. So as far as the regimen, new adjuvancy, there's our other options. Give a double block in this type and stage 1C, paclitaxel and trastuzumab, or trastuzumab and pertuzumab, which we would have given an adjuvancy, TDM1, or the sequential regime. In this case, we were inclined to give new adjuvancy with paclitaxel weekly and trastuzumab. In June of 21, she was submitted to partial mastectomy with sentinel node, and the histopathological report was a complete histopathological response. So this is what will be discussed in this debate, would be how would we continue with the adjuvancy with only trastuzumab, with TDM1, or with the complete regime of chemotherapy, or paclitaxel, initially. We decided to continue with radiotherapy, adjuvant radiotherapy, and trastuzumab only. Thank you.
Hello, I am Dr. Sarah Hurvitz from the University of California, Los Angeles, and I will be giving a talk that is promoting Hello, I'm Dr. Sarah Hurvitz
Hola,
from the
yo soy la doctora Sarah Hurvitz
from the University of
de la
California,
Universidad
Los
de
Angeles,
California, Los
and I will be
Ángeles,
talking
y voy a
about
estar hablando acerca
de-escalating
de
neoadjuvant therapy for small HER2-positive breast
desescalamiento
cancers.
de
So,
Geriatric Evaluation para
size does not
cáncer de
always
mama. La
matter.
ciencia
Even
no siempre
small
importa.
HER2-positive breast cancers
Aún
need
cánceres
systemic
pequeñas,
therapy. And I will also show you that timing does not matter because giving systemic therapy prior to surgery has been shown to improve the disease-free and overall survival to the same extent as giving therapy after surgery. If you know that a patient needs systemic therapy anyway, why not do it before surgery? Now, we know from historical data that HER2-positive breast cancer is associated with a poor prognosis, as shown here in the purple curve in the pre-trastuzumab era. However, data from trials like these in which patients who had HER2-positive breast cancer who were treated with trastuzumab are compared to patients with HER2-negative disease, you can see that trastuzumab has significantly improved the outcomes such that patients with HER2-positive breast cancer treated with trastuzumab have as good an overall survival as women who have HER2-negative disease now, as long as they're treated with trastuzumab. But we do know that some patients will continue to have relapses late in spite of having systemic therapy. As you can see here in the N9831B31 trials of adjuvant trastuzumab, up to 20% of patients will experience disease recurrence in spite of trastuzumab-based therapy. And so we have to keep this in mind and make sure that we are treating our patients with appropriate therapy to reduce their risk of relapse. Now, biology, in my opinion, matters more than size. That's what the data tells us. And even very small HER2-positive tumors should be treated with systemic therapy. We have data from the MD Anderson series showing very small T1A, T1B tumors that are HER2 positive have a much worse relapse-free survival than HER2 negative tumors. And NCCN series also showed the outcomes were worse for patients with HER2 positive versus HER2 negative, even when small. And the British Columbia series of stage 1 tumors similarly shows that HER2 positive breast cancer has a worse relapse-free survival at 10 years compared to HER2 negative if systemic therapy is not given. And so we know it needs to be given even when small, and the question becomes how much therapy is necessary. I would argue that a response-guided approach helps us gauge how much therapy we need to give. It allows us to start with a less toxic therapy and switch only to a riskier regimen if needed. And we know that residual cancer after neoadjuvant therapy is both prognostic and it predicts benefit from the use of adjuvant T-DM1. So why not give whatever therapy you're going to give prior to surgery to gauge whether or not the patient has a path CR? We know that path CRs are highest in patients with HER2 positive breast cancer, especially when the hormone receptors are negative. And we know that patients who achieve a pathologic complete response with HER2 positive breast cancer have a better event-free survival, so it's prognostic. We know that the residual patients with residual disease, a non-path CR, have a much worse outcome than patients who achieve a pathologic complete response from these modern HER2-targeted studies. And we know from the Catherine trial that those patients who don't achieve a path CR are able to be rescued by the use of adjuvant T-DM1, which increases their chance of being free from an invasive recurrence or from a distant recurrence at 3 years. And even clinically small tumors and lymph node negative tumors benefit from the use of T-DM1 if there is residual HER2 positive breast cancer, underscoring the importance of looking at the response to neoadjuvant therapy to assess how much therapy is needed after surgery. In contrast, just using an adjuvant approach yields much lower benefits. This comes from the affinity study in an unselected patient population. The benefit of pertuzumab for a year was very small, with a hazard ratio that is also very small and no survival benefit. So if the tumor is not responsive to whatever neoadjuvant therapy you choose, you can use T-DM1 in the adjuvant setting. And so you have an opportunity in a T1C tumor to choose a less toxic approach. Let's talk very briefly in the latter part of my talk about what regimens you could select. You could omit an anthracycline and use the TCH or TCHP regimen. And we have a lot of data to support these therapies. TCHP in the neoadjuvant setting was established in the Trifina clinical trial, where the pathologic complete response in the breast and lymph nodes was almost 64% in patients, and the progression-free survival was exactly similar to an anthracycline-based therapy. In the NeoCAR Chinese trial, TCH also shows significant benefits compared to an anthracycline ECTH regimen, with pathologic complete responses being higher in TCH, regardless of hormone receptor status, and the safety being better with TCH. And in the TRAIN-2 study, 9 cycles of a TCHP regimen was compared to 9 cycles of a regimen that included an anthracycline as well as platinum, the FEC-TH versus TCHP regimen. There was no benefit by adding the anthracycline. The path CR rates were exactly the same, in spite of the fact that these were high-risk patients with 2/3 having node-positive disease. Moreover, the progression-free survival, event-free survival was the same for patients, regardless of whether or not they received an anthracycline, and the safety was better for a non-anthracycline regimen, with fewer patients having a drop in their ejection fraction and fewer patients having leukemia from the anthracycline. I've compiled here a table showing all of the studies supporting a non-anthracycline regimen, which you could select for a small tumor. You could even select it for a large tumor and lymph node positive, given these studies all included high-risk patients. You could even omit the platinum and just do a THP type regimen or TH type regimen. We know from Sarah Tolani's APT trial that adjuvant paclitaxel trastuzumab yields a very good disease-free survival at 7 years for patients with small node negative tumors. And from the triple positive study, looking at pertuzumab, trastuzumab with either endocrine therapy or paclitaxel, you can see the pathologic complete response with the THP or paclitaxel, trastuzumab, pertuzumab regimen was 57% in this ER positive, HER2 positive breast cancer. The ADAPT HER2 positive hormone receptor negative study looked at omitting chemotherapy, just doing TH versus THP. And again, while omission of chemotherapy only yielded a 34% path CR rate, 91% of patients who received paclitaxel HP had a path CR in the breast and lymph nodes, underscoring the efficacy of this regimen in patients with small tumors to start with. And the invasive disease-free survival was 98% for the THP regimen. So here is a table showing the path CR rates that have been reported for a THP type of regimen, indicating that you can go forward without using the paclitaxel if you would like to reduce the toxicity in the neoadjuvant setting. You could also omit chemotherapy completely. Here is a summary of all the studies of dual HER2 targeted therapy without chemotherapy that I could find, and the path CR rates that you see. And as you can see, path CR rates are much lower in these clinical trials than you see when you add paclitaxel to the regimen. However, if you had a patient in whom chemotherapy is contraindicated, you could do an HP type of regimen, and if they have a path CR, might be able to omit chemotherapy in the adjuvant setting. So the verdict for chemo-free regimens is that while some patients achieve a path CR without chemo, the use of chemotherapy does increase the chance of path CR and remains the standard. So, in conclusion, in favor, my argument in favor of giving this patient neoadjuvant therapy for T1C HER2 positive tumors is that systemic therapy is still needed for small HER2 positive tumors. Old studies indicate that the timing of giving systemic therapy prior to or after surgery doesn't matter. So why not give it before surgery and learn about the biology of the tumor? And if the patient does not have a path
¿Mi pantalla?
Sí, por favor.
¿Estamos al aire?
Yeah. Dr. Hurwitz, please go ahead.
Okay, speak now. Oops.
Right.
Okay, so this is the last slide of my argument in favor of neoadjuvant therapy for small T1C HER2 positive tumors. We know that systemic therapy is still needed for small tumors. Old studies prior to Catherine indicate that the timing of systemic therapy doesn't matter in terms of long-term outcome. You can give it before surgery or after surgery and you'll have the same impact. So why not give it before surgery so that you can learn about the prognosis of the tumor and use that information if a patient has residual disease to give the patient TDM1 in the adjuvant setting. We also know that the neoadjuvant setting allows us to monitor for responses, allowing us to use less toxic regimens in smaller tumors like this, and using the response to gauge whether or not we escalate in the adjuvant setting. Thank you.
Sí.
Let's move on with Dr. Juarez's presentation, and then we will move on to the Q&A.
Alex, ahí estoy ya.
Adelante, por favor.
No sé si comienzo. ¿Ya estamos al aire?
Should I start? Are we live? Yes, please.
Bueno, buenas tardes ya para todos
Good afternoon to everyone. And I think that we have just listened to an excellent review, literature and of the benefits of anti-HER2 pre-op therapy. But on this specific patient that is presented by Dr. Hurwitz, I think that we can mention some arguments against, and especially more than debating the arguments that are clearly evident, arguments by Dr. Hurwitz. I would like us to delve into the case and in the treatment that was provided to this patient a little bit deeper. This is a patient to whom a treatment regimen known as the ABP regimen was given. This is a phase 2 trial. As you can see, that clearly changed the way in which we treat patients, but we have to remember that this is a trial that was administered in adjuvancy. This is a trial for patients with small tumors, as may be seen here. And this is a trial, again, for patients that have been operated on. And I would like to clarify this idea that although the size is not important, we know that things such as the nodes that are positive, the lymph nodes that are positive, goes hand in hand with the size or tumor size is important, so much so that the affinity trial demonstrated that patients with positive lymph nodes were the ones who derived the benefit. So in this patient, the first thing is that we truly don't have an absolutely clear idea as to whether the nodes are negative. And as you can see here, patients included in the trial, in the Delaney trial, were patients with positive nodes and with very small tumor sizes. smaller than 2 centimeters. And in the follow-up presentation at 7 years, what do we see? That as time goes by, as you can see here, paclitaxel and trastuzumab being administered make PFS not to be so good as was initially shown of 98.5%, but at 7%, we see a 93.3% of PFS. And in patients with negative lymph nodes, what we see is that we are at around 90.7% of progression-free survival, but this is patients with positive hormone receptors where progression-free survival is excellent at 95%. So as you can see, if we want to be really, if we want to keep close to literature, this is a trial where most patients, the vast majority of patients had very, very small tumors under 2 centimeters long. Only 36 patients, this is an absolute number, those that had tumors larger than 2 centimeters. Why is this important? Because in this specific patient, what we have is a clinical estimation, but we don't have a true estimation of the size nor the status of the lymph nodes. And if we see other adjuvancy trials, such as the TDM1, what do we see? That these are trials that are extremely loaded of patients with positive hormone receptor, 75%, as you can see here, of patients that entered the trial, comparing TDM1 versus trastuzumab and paclitaxel, will have positive hormone receptors, and our patient had negative hormone receptors. So, well, all of a sudden, this is an issue of the biology that needs to be borne in mind. And although the curves look quite similar between trastuzumab, paclitaxel, and TDM1, we can see that there is a discontinuation of therapy in 17% of patients that were given TDM1 versus only 6% of those that received trastuzumab with paclitaxel. This means that despite of the fact that toxicities may not be apparent, well, there is some reason why we are not seeing clearly within this standard toxicity assessment that makes a certain percentage of patients not to tolerate the therapy. And therefore, de-escalating in this manner doesn't seem to be a really serious de-escalation. But on this patient, we have a mass, and you know that masses do not estimate clearly lesion sizes. But we will apply if we are going to implement a de-escalation, I think these patients should be brought to surgery. And once that we have clearly in our mind the tumor size, be it by mammogram, that may overestimate or underestimate sizes, as well as the MRI, well, that would provide us a much clearer assessment on the patient staging. One of the big challenges that we have is how to objectively assess the patient's nodal state or status, nodal status. So this patient, in fact, her axillary nodal echo does not let us be safer with respect to her nodal status. Now, if we take a look at neoadjuvant therapy, and I know that Dr. Hurwitz showed you this, and I want to show you something quite similar to what she showed, but from a different perspective. We have treatments with trastuzumab, single therapy, and here we have all of the regimens where we combine pertuzumab with trastuzumab. And please observe that in none, except for the ADAPT-HER trial that was presented by her, will use therapy with paclitaxel and trastuzumab alone. Also, please see that historically we have used anthracyclines, docetaxel, and combinations where two regimens were combined with anthracyclines or a regimen with non-anthracycline or like in Bernice to see cardiac toxicity. And it is so that we see that in the Trend 2 trial, we have the comparison of anthracyclines and paclitaxel, but we have carboplatinum included in the treatment regimen. So the argument might be that for us to really be able to give a patient with small nodes that are negative and that are hormone receptor negative a therapy. Well, in neoadjuvancy, we truly don't have a very accurate information based on trials where we have used the regimen of only paclitaxel for 12 weeks. Conversely, what you see here is regimens that are a lot more intense and with benefits that are really substantial. If we know or if we believe in what Dr. Hurwitz says and what Dr. Cortázar showed us in her meta-analysis, where complete pathological response is really associated to a better outcome in the long term, as well as PFS and OS. It is these regimens, mainly with the use of more chemotherapy agents, that provide a better response in terms of complete pathological response. The TRIFINA trial, when we use an anthracycline or a regimen where no anthracyclines are used, we will see complete pathological responses that are quite important. But this is not a study, a trial with 12 weeks of paclitaxel, but it uses docetaxel, trastuzumab, paclitaxel, and a fourth agent. And all patients with negative hormone receptors will have a complete pathological response that is higher. The question here is whether only with paclitaxel we will be able to reach complete pathological responses of this magnitude in order to offer the patient a bigger benefit. Even in Sarah Toledo's trial, patients with negative hormone receptors will have an outcome in the long term that is slightly inferior than that seen in patients with positive hormone receptors. This is actually correlated. It correlates when we see neoadjuvancy trials versus adjuvancy trials. And the TRAIN trial, this is the other one for which we have long-term outcomes. Nowhere do we see a regimen of paclitaxel, trastuzumab, only for 12 weeks. And therefore, here on this trial, patients were staged with positive and negative nodes, and patients with small tumor sizes, T1, T2 versus T3, T4. And you can see the excellent results when a regimen of paclitaxel and carboplatinum was used, or a regimen with anthracyclines. The interesting thing for us on this trial is to see that we should not use anthracyclines, but anywhere does it show that a short 12-week regimen with trastuzumab and paclitaxel could be enough or comparable with these excellent results, as in the long term that we have a progression-free survival benefit and overall survival. Now, one more thing that we could consider would be trastuzumab de-escalation, and I would like to show you what the problem is with anti-HER2 de-escalation problems. First of all, we need to understand between the differences of a superiority or a non-inferiority trial. When a superiority trial is designed, here I show you the results, and it shows that the experimental therapy is superior when we have a result. As we see in A, there is no experimental result or outcome. When we have the blue example, we have an inferior treatment. Now, when we are looking at non-inferiority trials, well, of course, their purpose and their design is completely different. When we only want to demonstrate non-inferiority, there is a certain margin that is determined within the trial design, and the intent is to rule out non-inferiority. And non-inferiority thresholds are determined. The first non-inferiority trial that we proposed was a trial that actually did not show the non-inferiority, and it was a hair trial. But the barrier or the threshold of non-inferiority that was set was 1.15, and therefore the trial did not show the non-inferiority of short regimens with paclitaxel. Here we show the fair trial that was unable to show.
Después tuvimos el estudio Persephone y como ustedes saben, este estudio, el rango de no inferioridad se fijó en un momento, en un punto diferente al estudio de FAIR. Y lo que se encontró es que en este estudio en particular, sí se encontró que acortar el tratamiento con trastuzumab no era inferior a el tratamiento estándar de 12 meses. Sin embargo, cuando se lee bien el estudio, nosotros encontramos que hay algunos grupos de pacientes, como por ejemplo aquellos, nuestra paciente de 12 meses, algunos pacientes que debían continuar con los 12 meses de administración del trastuzumab, y estos eran de pronto aquellos pacientes que tenían receptores hormonales negativos, el uso de los taxanos como único agente, fíjense ustedes que esto se incluyó en el estudio Persephone, o el uso de la neoadjuvancia. Ahora,
Use of neoadjuvancy. Now, beyond HER and Persephone trials, well, you know that we have these 3 initial treatments comparing 12 versus 6 months. And there are there's another couple of trials that have compared 12 months versus 9 weeks. And in order to be completely honest, as you well know, this was a very interesting, there was an interesting presentation of Dr. Elena at ESMO, and she demonstrated her results in a meta-analysis where the non-inferiority point, or the non-inferiority limit, was set as at 2%, not 3%, as was the case in Persephone. And what they found was that when 12 months are compared to 9 weeks, non-inferiority cannot be demonstrated according to the trial. But when you compare 12 months versus 6 months, it is possible to find the benefit or the non-inferiority of the 6 months. Why is this important? Well, of course, it is important in our countries where we have limited resources, but it is also important to remember that our society finds it a lot more difficult to accept a loss than a benefit, than accepting a gain. So if I have to present the patient, and if I tell them I will shorten your treatment regimen, and with that you will only lose 0.7, as you can see, of benefit, accepting these losses of benefit, a benefit that is well known, turns out to be a lot more difficult for us, not only in medicine, but in any other situation. And that is why I think that de-escalating treatments such as trastuzumab can be important, provided that we discuss it with our patients. And thus, I would like to close. Thank you very much. Thank you so much to both of you for this wonderful discussion, providing shortened regimens with anthracyclines without pertuzumab. It's a difficult situation, and I would like to ask you, what regimen do you prefer to use in clinical practice in a patient with a small T1C tumor, a neoadjuvant regimen? And in that case, what regimen would you prefer? Or would you prefer to do it with adjuvancy? Did you get the question, Dr. Sarah? Yes?
Yes, I did.
Sí, sí, entendí la pregunta.
So it's very patient-based. So in some situations, if it is hormone receptor negative and high grade in a very young patient who has no comorbidities, I will offer them TCHP a la Trifena. But if it is a more indolent appearing tumor, if a patient has comorbidities that would place them at higher risk of a doublet chemotherapy regimen, I'm very comfortable with a THP type of regimen, similar to the ADAPT studies and similar to Sarah Tolaney's trial, just with the addition of pertuzumab, because I am convinced that the addition of pertuzumab will increase the chance of path CR.
Dr. Sandra, Dr. Franco, would you like to add anything? ¿Nos escucha, doctora Sandra? Dr. Sandra, can you hear us? Are there any questions from the audience? Well, otherwise, and as there are no more comments, we would like to thank both of you, Dr. Daniela, for presenting the case, and our two speakers, and we will move on with our program.
Doctora Franco, muchas gracias.
Yo no oía nada de lo que estaban hablando.
Sí, no sé qué sucedió porque acá nos escuchábamos bien, pero bueno, muy amable y gracias por todo.
Let's continue with the breast cancer module. We'll talk about neoadjuvant treatment with radiotherapy with a triple negative breast cancer, and the clinical case will be presented by Dr. Carmen Barrientos. She works in the Historian clinic in Guanajuato, and we'll have a discussion of the topic by Dr. Peter Smith from the Vice Cancer Institute in London. Good afternoon. I am Dr. Carmen Bermudez, and today I'm going to present a clinical case of a 37-year-old woman with a pathological history. She had paraplegia. She had a medullary lesion in her infancy due to a firearm injury. She is nulliparous and no previous anti-contraceptive. She began in October 2020 with palpation of a painful node in her right breast. The physical exam, she is obesity grade 2. In the upper outer quadrant of the right breast, there's a 3-centimeter node. In the ipsilateral also, there is a 3-centimeter node, which is mobile. At the ultrasound by red for B with hyperechoic lesion of 3 centimeters. True cut biopsy is reported positive for infiltrating ductal carcinoma, partially differentiated and with vascular permeation. There's a axillary lymph node, which is positive for carcinoma. CAT scan is done with no distal disease. And so it's classified as clinical anatomical 2B and prognostic staging 2B. The BRCA panel was conducted, was negative, and we began to neoadjuvancy based on ACA+T thrice weekly. These patients benefit from dense doses. However, by logistics, the mobility of the patient, we had to decide for this regimen. The first question: in your clinical practice, do you indicate platinum salts in the neoadjuvant treatment of triple-negative breast cancer? Only in case of mutations BRCA, B, only in young patients, C, only in advanced local disease, D, yes to all, or E, never. This patient was had a radical mastectomy after adjuvancy, and the lymph nodes were also resected. In the histopathological report, we find a breast without evidence of residual disease and metastasis to 2 lymph nodes in the axilla without capsular rupture, but with present extracapsular disease. So we conclude that we didn't achieve the complete pathological response. We received adjuvant radiotherapy to the axilla and the chest wall, and subsequently began capecitabine and adjuvant therapy. Second question: in the case of triple-negative breast cancer, in the cases with residual post-adjuvant chemotherapy disease, do you indicate adjuvant capecitabine? A, yes, conventional dose. B, yes, metronomic dose. C, no. And here we have these studies in phase 3 with the use of capecitabine. We decided to employ the CREATE X protocol, which is in patients with residual disease post-neoadjuvancy, and with positive and initial results. And in the TF-negative population, we know that there's a second study, which is a Spanish study, which unfortunately is negative in its outcomes. But recently we had the third study, which was published in JAMA and was also positive through outcomes with the use of capecitabine as adjuvant treatment. Currently, the guides of the NCCN recommend the use of capecitabine in residual disease and triple-negative cancers. However, with the use of platinated salts, it is still controversial, even in muted BRCA. With the information that currently exists, should we consider the use of immunotherapy, neoadjuvant therapy in triple-negative breast cancer? A, yes. B, no. C, there is still not sufficient information. As we well know, recently the results of Keynote 522 and Impassion 031 were positive and very encouraging for this type of patients in neoadjuvancy with the use of immunotherapy. And this is when the NCCN in its last update recommend the use of pembrolizumab in neoadjuvancy, triple-negative. And next, Professor Schmidt will discuss further this topic. Thank you very much. Es un placer hablar con ustedes acerca del papel de la inmunidad
Adelante.
First advantage is we can substantially downstage the disease and therefore facilitate less invasive surgery to the breast, but equally, or possibly more importantly, to the axilla, where we can enable a higher rate of sentinel lymph node biopsies, but also facilitate targeted axillary dissection. The second and most important point is we can divide patients into two groups, a group of patients who have what we call a pathological complete response, disappearance of all invasive and non-invasive tumor from the breast and axillary lymph nodes, and those patients have a fantastic outlook. Whereas we have a second group of patients who still have residual disease left at the time of surgery, and these patients unfortunately have a substantially higher risk of recurrence, as the meta-analysis, which you can see on your slide, has clearly demonstrated. The benefit or the better outcome in terms of event-free survival has a hazard ratio of 0.24 for path-CR versus no path-CR, and 0.16 for overall survival between path-CR and non-path-CR. But equally important in this setting is we're also learning that we can modify the risk of those patients in the high-risk group with residual disease, for example, with capecitabine, but we'll also discuss that there are other treatment strategies we can use. With this in mind, the strategy for triple-negative breast cancer is very clear. Most patients should be considered for neoadjuvant chemotherapy, and then we escalate or de-escalate at the time of surgery depending on their response. Now, is there a way of increasing the response rates to neoadjuvant chemotherapy? And the first drug we really looked into, and has been ongoing debate for the last 10, 15 years, is the role of platinum. Now, we know without platinum, with anthracyclines and taxanes, the path-CR rates are only in the range of 35 to 40%. And there are 3 randomized trials that looked into this question. As you can see, with the addition of platinum, we consistently have approximately 15% higher path-CR rates, consistently path-CR rates in the 50% plus group. But the reason why for many years it wasn't a standard recommendation to use platinum in stage 2 or stage 3 disease was that the long-term benefit was less clear. The German study showed about a 10% difference in disease-free survival, which is important and significant.
Wait a moment.
The American study showed about 5% difference, which was not significant because a relatively small study. But recently at ESMO, we saw long-term follow-up data from the Brightness trial, which again, in keeping with the German trials, shows a 10% difference in event-free survival at 4 years' time, which is significant, and in my opinion, should end the discussion whether patients should receive or not neoadjuvant platinum-based therapy. In my opinion, is very clear. Chemotherapy should, in the majority of patients, contain platinum, irrespective of whether patients are BRCA1 or BRCA2 mutation carriers. Is there a way that we can improve outcomes in patients who do not achieve a path-CR? So can we salvage those patients who have residual disease? And the answer is yes, we can in triple-negative breast cancer. There is a trial with capecitabine chemotherapy called CREATE-X trial. It's performed in Japan and Korea mainly, and patients with stage 1 to 3B disease receive neoadjuvant platinum-free chemotherapy. If they had residual disease at the tumor, received capecitabine or were just observed. And as you can clearly see, there's a substantial benefit in survival with a hazard ratio of 0.52, clearly suggesting that these patients should be considered for adjuvant treatment with capecitabine. More recently, we've seen data in patients with germline BRCA1 or BRCA2 mutations with a PARP inhibitor olaparib in the very same situation. Patients with early stage disease who had residual disease after neoadjuvant chemotherapy either received olaparib for a year or placebo, and we can see a substantial benefit with a hazard ratio of 0.58 in this setting. So yes, we can improve outcomes of patients who don't achieve a path-CR, which is another clear reason why to give the treatment initially in the neoadjuvant setting. And we are exploring more effective targeted therapies in the adjuvant setting, which in my opinion are likely to even more improve the outcomes. For example, some of the new antibody drug conjugates, which we're not discussing today. Now, moving on to immune therapy, which is probably the biggest change we will see in the next few years in the treatment of stage 2 and stage 3 triple-negative breast cancer. There are 2 randomized phase 3 trials that looked into the role of immune therapy in this setting. The first one, KEYNOTE-522, a large phase 3 trial, 1,174 patients, intensive chemotherapy strategy with paclitaxel carboplatin with or without pembrolizumab, followed by AC or EC with or without pembrolizumab, then surgery, and then adjuvant placebo or pembrolizumab continued. The trial had 2 primary endpoints, a short-term endpoint looking at path-CR rates and a long-term endpoint looking at the reduction in recurrences in form of looking at event-free survival. We have a second trial, smaller phase 3 trial called IMpassion031 with only 333 patients, 1-to-1 randomized, platinum-free chemotherapy with nab-paclitaxel followed by accelerated AC with or without atezolizumab. Because of the trial was small and patients were unblinded after surgery, the trial is only really set up for looking at path-CR in the first instance. Overall, those trials are relatively similar, although KEYNOTE-522 included more patients with no positive disease, 52 versus 38%, rest very comparable. If you look at the first primary endpoint of both trials, there's a remarkable consistency, and both trials are significant in terms of path-CR rates. In KEYNOTE-522, the increased path-CR rates from 51 to nearly 65%, nearly 14% delta. Very similar results, but starting on a lower level because of less effective chemotherapy, from 41% with chemo to 57% with chemo and atezolizumab, against 60% difference in IMpassion031. If you look at the now long-term outcome data we had recently presented at the ESMO meeting, we see that the significant benefit in path-CR rates is now also translating into a significant reduction in recurrences with 39 months follow-up. We see that the 3-year event-free survival rates are about 8% different, 84% versus 76%, hazard ratio of 0.63. In other words, a 37% reduction in events, recurrences, local or distant. If you look at the number of events, 23.8 versus 15.7, this is a significant and meaningful difference. If you look at some of the subgroups of interest, on the left side, you see the path-CR rates by nodal status. And what was striking when we first presented the data 2 or 3 years ago, we saw that patients with nodal involvement have a similar path-CR rates if they receive immune therapy compared to patients who don't have nodal involvement. So almost an overproportional benefit in path-CR rates for patients with nodal disease. However, if you now look at event-free survival, long-term outcome, both groups derive as comparable benefit, hazard ratio practically identical in patients with no positive, no negative disease, stage 2 or stage 3 disease. Equally interesting, looking at PD-L1 staining. We know from the metastatic setting that patients with PD-L1 positive tumors don't derive a substantial benefit, whereas patients with PD-L1 negative tumors don't derive a benefit of immune therapy. This is different in the early disease setting, where patients benefit from the addition of immune therapy, regardless of the PD-L1 score, whether negative, low, or high. The relative benefit added by immune therapy seems to be comparable. And this is probably down to the dynamics in the tumor biology and the plasticity of those tumors. We have data showing that tumors that may be PD-L1 negative at the beginning of therapy can turn PD-L1 positive within 2 or 3 weeks from starting on chemotherapy and immune therapy. 2 secondary endpoints also show very strong and encouraging results. On the left side, you see distant recurrent-free survival, significantly better in patients with immune therapy compared to patients with chemotherapy alone. Hazard ratio 0.61, 39% reduction in the occurrence of metastases. And with a relahazard short follow-up for survival of 39 months, we also see a clear separation of the curve starting hazard ratio at this time point 0.72. We will follow up longer until we see a significant result here. A really interesting result is looking at the outcome between the different treatment groups, the immune therapy or no immune therapy, depending on whether patients achieved a path-CR or not. It's a pre-planned analysis. And as you can see, patients who achieve a path-CR do very well with both treatment strategies, chemo alone and chemotherapy and immune therapy, although patients who receive immune therapy still have 2% better event-free survival, even if they have a path-CR rate. The hazard ratio is 0.7 for this subgroup. But really striking is the result for patients who do not achieve a path-CR, who have residual cancer, where many of us feel tempted to say where immune therapy didn't work optimally. Well, having said that, these patients have a substantially better outcome if they received immune therapy with a nearly 11% higher event-free survival rate, 67% versus 56% without immune therapy. In this setting, and the hazard ratio, again, is around 0.7. So my conclusions from this sub-analysis is that the presence of a PCR benefit is and remains predictive of long-term outcome, but the absence of a PCR benefit doesn't mean the treatment didn't work. So even if patients don't achieve a path-CR benefit or treatments don't induce a path-CR benefit, they may still lead to a substantial benefit later on in terms of event-free survival. If you look at the side effects, the most common side effects in the neoadjuvant phase clearly dominated by chemotherapy. You see in green the pembrolizumab group, in red the placebo group together with chemotherapy, a very little difference in the most common side effects. If you look at the adjuvant phase, treatment-related side effect, very little difference between both treatment groups and a relatively low incidence of side effects at that point in time. No new safety signals were identified, and what we see is very much in keeping with what we've learned from other studies with immune therapy in this setting. We have to zoom in to really understand a little bit more what immune therapy can cause in terms of side effects. And if you look at the right top half of the slide, immune-mediated side effects in combined phases of chemotherapy and immune therapy, and on the left bottom half, the patients who receive it in the adjuvant setting. And again, they are relatively rare. We see a higher incidence, obviously, with patients treated with immune therapy, predominantly driven by endocrine side effects, thyroid changes, and skin reactions. They occur mainly in the neoadjuvant phase, so very early, and it's a low risk during the adjuvant phase, and a very low risk once patients have stopped the therapy. These adverse events are generally low grade, successfully managed with interruption, sometimes require steroid administration, sometimes hormone replacement, especially for thyroid. And it's, of course, as always, important to identify those side effects early and intervene early to make sure that patients stay safe. We will continue to follow up these patients, but at the moment, there are no signals for late toxicities. Now, there are still some questions open. And one of the interesting questions is that not all studies have shown the same benefit. I shared with you the 2 phase 3 trials that have read out so far, showing a clear benefit in path-CR rate, and for 5-2 also in event-free survival. Now, interestingly enough, there's an Italian study called NeoTrip, which had an anthracycline-free chemotherapy regimen, intensive platinum taxane regimen with and without atezolizumab in a high-risk group of stage 2 and stage 3 disease. And this trial failed to show a difference in path-CR rates in the first analysis. However, it has to be stressed that path-CR is only the secondary endpoint for this trial. The primary endpoint is still pending, and that will look at event-free survival. And with the learning we just had from 5-2, it is still conceivable that even this trial may lead to a long-term benefit. But until we have those data, I would use this trial as a note of caution, not to change the chemotherapy regimens and just stick to the regimens we know, because with those regimens, we have clearly seen a path-CR benefit. Whereas if you switch to anthracycline-free regimens, as here, you may or may not see the same benefit. There are some other immune therapy trials still ongoing, different designs. We've already spoke about the neoadjuvant concept, which I believe is optimal in terms of antigen release. On the other hand, may lead to some possible overtreatment, because some patients, as we can see, do already very well with chemotherapy alone. And we need to work out the benefit of the adjuvant part of this therapy. We have also been looking into trials in patients with suboptimal response, bringing immune therapy in halfway through. But I would be a little bit cautious about those concepts, because if we add immune therapy at a later stage, we may see less antigen release. On the other hand, allows us to select a really high-risk group. There are adjuvant studies ongoing, which are ideal from a patient selection point of view to some degree, but again, there's some note of caution, some concerns around the minimal or lack of antigen release once the cancer has been removed, and we will have to see whether we can still induce the same immune response in those patients. And there are interesting studies in patients who will receive neoadjuvant chemotherapy, have residual disease, high-risk disease, and to give them single-agent immune therapy, which is, from a clinical point of view, an interesting concept. But again, the same concerns around the lack of antigen release need to be applied. And we know that single-agent immune therapy has only limited effect. Let me finish with a few thoughts on where the journey may be going. We have only seen immune therapy data for stage 2 and 3 triple-negative breast cancer. Stage 1, we don't know whether immune therapy will or may play a role. But a lot of discussion is ongoing at the moment around de-escalation strategies. And one of the considerations could be to add in immune therapy to possibly de-escalate chemotherapy, possibly chemo-free combinations, for example, with antibody-drug conjugates, which allows us then only give chemotherapy to those patients who don't achieve a path CR. In stage 2 and 3 disease, we have a new standard of care with the addition of immune therapy to chemotherapy, but there's still work to be done, for example, around the role of platinum, whether everyone needs it, and possibly whether we can identify optimal responders. In patients who do achieve a path CR, we will have to work out to what degree the adjuvant therapy benefits patients. And in patients with residual disease, where still a third of those patients experience, unfortunately, disease recurrence, we will need to look at more effective combinations. Combination, for example, chemotherapy with immune therapy, or in my opinion, very promising antibody-drug conjugates with immune therapy. This is where we are with immune therapy. For me, immune therapy is there to stay in the neoadjuvant setting. I think we've managed to shift the outcome substantially higher with a roughly 40% reduction in distant recurrences, which will translate into a survival benefit. This puts immune therapy on the map, but it will be down to us to work out how best to give this in the future, whether who are the patients who benefit most, and look into other indications. Thank you very much.
Después de esta excelente plática, no habrá preguntas. El doctor no está conectado en línea.
Doctor's not online, so we don't have opportunity for Q&A. We'll go on to the next presentation, which is titled Change in the Role of Chemotherapy and Hormone-Positive Receptor Tumors. It will be presented by Dr. Eric Miner. He is director of the breast cancer program for Dana-Farber Cancer Institute in Massachusetts in the U.S. Go ahead, Doctor. Thank you for being with us.
Okay, Doctor. Your presentation on the presentation mode, because I think we are just missing your desktop.
Okay. Mode.
Okay. 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 Now I can see you on the camera. Can you go to the next slide, please?
Sure. Go to the next slide. Great. Can I start? Good afternoon. I'm Eric Weiner, as you heard, presently at Dana-Farber Cancer Institute. I'm actually moving to be the Cancer Center Director at Yale in February. But in any case, what I want to speak to you today about is the evolving role of chemotherapy for estrogen receptor positive breast cancer. So what you can see from these SEER data is that throughout a woman's life, she has a relatively constant risk of developing triple negative or HER2 positive breast cancer. In fact, as a woman ages, the risk of developing these cancers goes up a little bit, but not so very dramatically. In contrast, shown on the far left-hand portion of the slide, women who have hormone receptor positive and HER2 negative breast cancer have a much, much higher incidence of developing breast cancer as they get older. This is from a paper that my colleague Hal Burstein wrote, a review in the New England Journal of Medicine, looking at the heterogeneity of ER positive and HER2 negative breast cancer. You can see that these cancers range in grade, that there's variable ER expression, that there are both ductal and lobular cancers, and that, of course, the proliferation of the cancers varies a great deal. Some are much more proliferative. For example, the grade 3 ductal cancer in the middle. Others are much more indolent. And of course, this also correlates with the score on the Oncotype Dx recurrence score and presumably on the results from mammoprint assays and other prognostic tests. Among patients who have very small cancers, that is T1A and T1B node negative cancers, the outcome in the absence of chemotherapy is truly excellent. This comes from my former colleague, I.S.S.T.E. Vasse-Louise, who is now at the Institute Gustave Roussy in Paris. And what she did was look at the NCCN database and look at outcomes for patients with T1A N0 and T1B N0 ER positive breast cancer. And none of these patients were treated with chemotherapy. And what you can see is extraordinarily favorable outcomes with overall survival in the 97 to 98% range, breast cancer specific survival in the 99 to 100% range, suggesting that in these patients, there really is no value to the use of chemotherapy in addition to either endocrine therapy or in some cases, no therapy. Now, the study, among others, that led to the widespread use of chemotherapy in patients with node-negative ER-positive breast cancer for over 2 decades in the United States was NSABP-B20. This was a relatively simple study. It was started in the early 1990s, and it had an influence on practice, again, for a long period of time. It randomized patients who had ER-positive, node-negative breast cancer to either tamoxifen alone or tamoxifen plus 2 different chemotherapy regimens. The results shown here demonstrated an improvement in disease-free survival, distant disease-free survival, and overall survival associated with the use of chemotherapy across the entire population. That said, this improvement in both distant disease-free survival and overall survival was of relatively modest proportions, largely because the patients who received tamoxifen alone still did quite well in the absence of chemotherapy. So there wasn't that much room for improvement. And the improvement overall was about a 5% improvement in terms of disease-free survival, less in terms of overall survival. In 2000, so now 21 years ago, the NCI had a consensus conference, and truly, much to the horror of many who watched that conference, concluded that adjuvant chemotherapy should be considered in all patients with positive lymph nodes. Most people did not have an argument with that, but that in addition to that, it should be considered in all patients with node-negative disease as long as the tumor was greater than 1 centimeter. And many of us at the time were concerned that this would lead to a significant amount of overtreatment. Now, several years later, Soon Paik and others applied the recurrence score, the Oncotype Dx recurrence score, to the NSABP-B20 population. And what you can see in panel A is the overall result in terms of the proportion that are free of a distant recurrence. And what you can see in panel B and panel C are the results in patients who had low or intermediate recurrence scores. Clearly, in the setting of low recurrence scores, the curves appear to overlap entirely, suggesting no benefit for chemotherapy. Somewhat less clear in the intermediate group. And among patients with high recurrence scores, a very clear benefit, albeit in a retrospective analysis, associated with the use of chemotherapy. And I might add that this is a benefit not dissimilar from the benefit we see with chemotherapy in triple-negative disease. This is the likelihood of distant recurrence by recurrence score and treatment arm. And what you can see is that there seems to be a benefit for chemotherapy treatment that's shown in the red line versus the blue line, but that difference only emerges among women who have higher recurrence scores. So below a recurrence score of approximately 15 or even 15 to 25, the difference is really very modest, but the curves start to separate much more so as the score is above 20 and even more so when it's above 30, 40, and 50. Sorry about that. So that led to the Taylor-X study. And this study, I think, is familiar to you, but I think it's important to review it. In this study, patients with node-negative, ER-positive breast cancer were enrolled and all had an Oncotype Dx. Those with scores of less than 11 were assigned to receive hormonal therapy alone in arm A. Those with scores of greater than 25 were assigned to receive chemotherapy plus hormonal therapy. And sadly, we have no data from that group of patients. And those with so-called intermediate recurrence scores, which in this study was defined as 11 to 25, were randomized to chemotherapy or not. Now, among women who had scores of less than 11, the outcomes were truly pristine. At 5 years, the distant relapse-free survival was 99.3%. And at 8 years, the distant relapse-free survival was 97%. And I think from those numbers, it becomes clear that you can't do much better and there would be no value associated with the use of chemotherapy. Moreover, the benefits of chemotherapy, as you know, are almost exclusively seen in the first 5 years. So in fact, here with a 5-year result of 99.3%, we really can't make it any better. And it's unlikely that chemotherapy, given at the time of diagnosis, would have any impact on later risk of recurrence. Among the randomized patients, and there were over 6,600 randomized patients, overall, there appeared to be no benefit in either invasive disease-free survival or freedom from recurrence at a distant site. You can see the very clearly negative results, both in terms of the curve and p-values of 0.26 and 0.48, with hazard ratios that are very close to 1. There was, however, some limited suggestion of a benefit in younger women and in an exploratory analysis of chemotherapy benefit in women less than or equal to 50, of which there were 2,200 such women. Among women who had recurrence scores of 0 to 15, there was no benefit similar to the overall population. Among women who had scores of 16 to 25, in the 16 to 20 group, there seemed to be fewer events, but there was only a 2% reduction in distant recurrence. So I think one can conclude that there's little benefit in terms of distant recurrence. A somewhat larger benefit in women who had scores of 21 to 25, since there were 6% fewer events, and most of these were distant recurrences. But there is one very important point, and that is that only 15% of these patients received ovarian suppression. The majority of these women were over the age of 40. And what that means is that almost all of the women who received chemotherapy would have expected to go through chemotherapy-induced menopause. And so it is very possible that any benefit seen in the premenopausal women was largely a result of ovarian suppression. And we know from the SOFT trial, shown here with 8-year follow-up, that the addition of ovarian suppression to tamoxifen or giving it with exemestane is associated with a clear benefit, a benefit that in terms of magnitude is very comparable to the benefit that I just showed you. In Taylor X, of note, the benefit from chemotherapy in those younger women was almost exclusively in women who were between the ages of 41 and 50, and in fact, women less than 40 who were unlikely to go through menopause with chemotherapy seemed to get no benefit from the chemotherapy. So the takeaway messages from this study, conducted exclusively in node-negative patients, was that for women over 50, there is clearly no benefit for chemotherapy with a recurrence score of up to 25. The result, in my mind, begs the question of chemotherapy benefit, for example, in women who have scores of 26 to 30, since if there's no benefit at 25, do we really think there's suddenly a big benefit at 26? And for women under 50, there's virtually no benefit up to 20, with some benefit in the 21 to 25 range, but that may be due to ovarian suppression. And I will tell you that as a group, our breast cancer program generally treats most of these patients with ovarian suppression rather than chemotherapy, particularly in the node-negative setting. Now, these patients were at relatively low risk of disease recurrence. On average, the cancers were 1.6 centimeters, grade 2. The patients tended to be postmenopausal. And of course, once again, all were node negative. There have been data in the node positive setting that came out before the RxPonder trial. This is from an Israeli database that looked at the 5-year outcomes in women with N1-MYC and N1 disease who had recurrence scores of 0 to 17, suggesting that in those patients with low recurrence scores, the outcome shown in gray is extraordinarily good in the absence of chemotherapy. And in the German Plan B study, women with node-positive disease who had scores of 0 to 11 also had a very favorable result. But of course, it's RxPonder that was reported in the last year that has given us even more information, albeit confusing information. So in this study, women who had recurrence scores of 0 to 25 and had 1 to 3 positive lymph nodes were randomized to endocrine therapy alone or endocrine therapy plus chemotherapy. Overall, there was a very small benefit associated with chemotherapy, a benefit at 5 years of 1.4% in terms of the reduction in invasive disease-free survival. And certainly for most of my patients who I talk to in clinic, a 1.4% benefit in terms of a reduction in disease-free survival is not sufficient to take therapy. However, this did seem to vary by menopausal status. Among postmenopausal women, there was absolutely no benefit for chemotherapy in this group of women with 1 to 3 positive nodes. And yet there was an approximate 5% improvement in outcome for premenopausal women. And as you will see in a minute, that improvement was seen, albeit of slightly different magnitude, among women who had scores of 0 to 13, as well as scores of 14 to 25. So this is now dividing it up according to the recurrence score result. Again, in postmenopausal women, no benefit. In premenopausal women, benefit in both groups, although because there is a lower risk of disease recurrence in the women with lower scores, as you can imagine, the potential benefit of therapy was less. And in terms of overall survival by menopause, nothing in postmenopausal women. maybe a very small suggestion of an early survival benefit in premenopausal women. But the magnitude of this benefit is about 1% at the 8-year mark. Now, we also have other data in node-positive patients, and these data come from the MINDAC study in which MammaPrint was used. I could try to explain MINDAC to all of you, but the truth is that it is one of the most confusing studies in my mind that has ever been put forward. And the bottom line is that the most useful result in MINDAC is shown here. And this is the freedom from distant metastasis among the 644 patients, many of whom had lymph node positivity, who were of high genomic risk, of low genomic risk and high clinical risk. And what they showed in this group of women, who included women with 1 to 3 positive nodes, is if the genomic risk was low, and that's similar to an Oncotype Dx of less than 25. I mean, we don't know for sure. It's absolutely equivalent, but that's the basic idea. That the observed 5-year distant metastasis-free survival was 94.7%, and they considered any score that was in this range to be indicative of a lack of significant benefit of chemotherapy. Looking at an intention to treat result in the discordant patients according to randomization, what you can see is that the distant metastasis-free survival in patients who had clinical high and genomically low disease is shown here, no apparent benefit. And in patients, for that matter, who had clinical low-risk disease, that is very small node-negative tumors, but genomically high, again, no benefit. And in MINDAC, the benefit that was seen was in patients who had both clinical high-risk disease and genomically high-risk disease. So just to come to the end, first, which postmenopausal women should receive chemotherapy for ER-positive breast cancers? And then I'll come to the more difficult issue of premenopausal women. So in my mind, clearly, no postmenopausal woman should receive chemotherapy if she has a tumor of less than 1 centimeter in the node-negative setting. In that node-negative setting, I think it's reasonable to consider chemotherapy for a woman with a somewhat larger tumor that is larger than 1 centimeter, with an Oncotype score of greater than 30 or a high MammaPrint signature. In patients with 1 to 3 positive nodes, I would give chemotherapy for a score that's above 26 to 30, but would not give it to anyone who has a score of 25 or less. And what about in patients with more than 3 nodes and low scores? Do we have to give them all chemotherapy? At the moment, the standard of care is for a woman with 4 nodes or 5 nodes or 6 nodes to routinely get chemotherapy. But if that woman has a very low recurrence score, it's hard for me to get so excited about it. And the truth is, we're never going to have an answer to this question because there'll never be a randomized trial. And I think it involves a case-by-case discussion. You have to consider all of the prognostic factors. And my answer would be different in a woman with 10 positive nodes than a woman with 4 positive nodes, and different in a woman with a very large tumor than a very small tumor. And this is also where patient preferences are key. What about premenopausal women? I still would avoid chemotherapy in node-negative patients who have tumors less than or equal to 1 centimeter. For node-negative patients, I would never give chemotherapy with an oncotype of less than 16 to 20, but would discuss it in a woman who has that higher intermediate score of 21 to 25, although I think that ovarian suppression is a very reasonable alternative that I would generally favor. For node-positive patients with 1 to 3 nodes and a score of 0 to 25, our expounder found a benefit for chemotherapy. But ovarian suppression, in my mind, remains an alternative for many. And in making that decision as to whether to substitute ovarian suppression, I would consider the specific Oncotype score. My answer would be different, with a score of 3 than 23. I'd look at other features of the tumor, the exact number of nodes, the size, and of course, patient preferences. And in premenopausal women, for those who do have 4 or more positive nodes, or 1 to 3 with a score of 25 or a high mammoprint, at this point in time, I would give chemotherapy. I will tell you that there are plans for a US trial with some international participation for the group of women who have 1 to 3 positive lymph nodes, looking at optimal endocrine therapy. That is, excuse me. Sorry. That is an aromatase inhibitor and ovarian suppression with or without chemotherapy, since of course one of the problems with our responder was that in that study, like Taylor X, very few women received ovarian suppression. Are there genomic predictors that can help us pick the optimal chemotherapy? The answer here is a resounding no. And so in closing, who should get chemotherapy and where are we? The use of chemotherapy has clearly declined and will continue to decline, but we do have to be thoughtful and we don't want to deprive people of benefit. In a limited group of patients, there is clearly a substantial benefit from chemotherapy, as I mentioned, probably similar to the magnitude of benefit seen in triple-negative disease. I'm always hesitant to back off when the patient is that much younger, when the tumor burden is larger, when the findings from the clinical assessment and the genomic assessment are discordant, and of course, in the patient who says that she's willing to take a toxic therapy, even for a very small benefit. In that patient, I'm much more likely to opt for chemotherapy. And with that, I will end and thank you very much.
Thank you, Doctor, for your presentation. Are there any questions from the audience for Dr. Weiner regarding this presentation? I would like to ask him if in patients, premenopausal patients with positive lymph nodes, in your clinical practice, would you use Oncotype or some genomic signature due to this controversy about whether or not there is a certain benefit from chemotherapy for these patients according to the score?
Yeah, so I would use a genomic predictor like Oncotype in those patients where if the score were 25 or less, and particularly it's possible you would make a different decision at 25 than 15, but in patients where there is some score where you would be willing to give something other than chemotherapy. And for us and our group at Dana-Farber, there are many of those patients. We wouldn't typically in somebody with grade 3 disease. We wouldn't typically in somebody who has a 7-centimeter tumor and 3 nodes and less than strong ER, but we would in many other patients.
¿Considerarían en pacientes?
Would you consider in very young patients, would you consider using genomic signatures, for example, under 30 years of age?
So I will tell you that we tend not to think of very young patients as being fundamentally different, apart from the fact that we know that they have a different mix of tumors and that one has to take a different approach in the ER positive patients in terms of endocrine therapy, since those patients, of course, never go through ovarian suppression with chemotherapy alone. So I'm always a little more hesitant in women under the age of 30, but I wouldn't rule out doing it. And again, it would be based on all of the factors that I showed you, including patient preferences.
Muchísimas gracias, doctor.
Thank you very much, Doctor. And with this, we will close this module and we'll go on to the next one. Thank you very much, Doctor.
Thank you so much for having me.